excited to have Professor Anita Ho here, although I think it's at least somewhat misleading to use the honorific professor, given that her work is, not only academic. It spans across academic contexts, of course, but also clinical and business contexts. Still, Anita is associate professor at the Center for Applied Ethics at the University of British Columbia and at the University of California, San Francisco Bioethics Program, which is, I guess, where she's coming from today. She's also a scientist at the Center for Health Evaluation and Outcome Science and the Regional Director of Ethics, Northern California for Providence St. Joseph Health. So I think it's safe to say that Anita wears many hats, bioethicist and health service researcher with training in philosophy, clinical and organizational ethics, public health, and business, and she is a classically trained pianist to boot. And so when I, went on the Google Scholar page and started, thinking I could list Anita's publications and research interests, I thought, wow, this sounds a lot like, the best bioethics textbook you could ever read, in the sense that she's researched and published so widely on so many topics of interest. And she's someone whose work I've always looked up to since I, came in the field. And I've just been so impressed by the topics she's written about, ranging from disability issues, the ethics of clinical trial design, end-of-life care, especially relevant to the medical aid in dying debates here in Canada, autonomy, informed consent, genetic testing, healthcare resource allocation. She's done a lot of great work on cross-cultural and global health ethics. And I, for one, really appreciate how she's able to do all this research, not only theorizing from the armchair, as many philosophers do, but she's also able to, I think, really successfully integrate methods, empirical methods, like from the social sciences, to study these important and pressing issues. But I was most excited to invite Anita here to speak to our group at Care AI, because I think she's really a leader in the increasingly important field of AI in healthcare and in medicine. And so I think that would have been true, even a year ago, but a lot of the trends that she's been writing about and interested in have only been accelerated since the onset of the pandemic. So I'm really excited to share that Anita is currently completing a book manuscript on AI health monitoring ethics to be published by Oxford University Press. And so for those of you, maybe not in the humanities area, this is, for sure the top and most prestigious press in the field. I think the book will be of interest to this group. We'll probably hear a bit about it today. And the last thing I want to highlight in this area is that I think Anita's work, she's done, this really exemplary job of writing on important but underexplored topics in the ethics of AI. So we'll hear a little bit today about some of the issues in elder care, which, as far as I can tell, she's one of really the only or at least one of only a few people working on this area. And she's also done some really interesting work on strategies for developing equitable AI interventions in the context of the opioid epidemic. So hopefully in this brief intro, I've been able to give everyone a sense of the really impressive and wide-ranging work that Professor Ho has done. And just wanted to say we're thrilled to have you here. And with that, we'll hand it over to you for your talk.
Thank you so much, Gus. That's a really extremely generous introduction here. So let me see if I could share my screen so that I could share my slides here with you. I don't know what you see.
So we've got the kind of like not the presenter view, but just the full kind of PowerPoint view here.
Okay, so do you see full slide? Okay, thank you so much. I'm really pleased to be here, even though that means at my office desk right now. But thank you again so much for the invitation and the opportunity to share some of my work and ideas. And in some ways, I kind of feel like when Professor Scorber was just talking about some of the work I've been doing, I keep thinking, there is a method to my madness. So I'm hoping that a lot of what I have done in different areas in relation to disability, elder care, of course, right now with the pandemic as well, how we actually think about AI applications, particularly in relation to health monitoring, in a way that could be ethical. I probably won't be able to get through all of those issues that I have been thinking about, but I'm hoping that this will at least give you a snapshot in terms of some of the work that I've been looking at in relation to health monitoring. Today, I would be mostly focusing on elder care. And I'll share a little bit about a project that I'm working on right now as well, that's being funded by the CIHR, if we have time. I want to again thank Gus, if I may say that, for the invitation and CareAI and having me here. I also want to thank Emerson Collective. This year I'm a fellow working with them on AI or digital health monitoring, particularly in relation to the pandemic. What are some of the justice considerations when we think about health monitoring, especially now that in the pandemic, it seems that a lot of things that we generally think would be a violation or at least some kind of intrusion of privacy is now much more widely accepted. And you hear that today as well when I talk about some of my work. How does that actually possibly shift the way that we think about privacy in general and perhaps the utility of monitoring? And could this trend also stay beyond the pandemic as well? I also want to give a shout out to my publisher editor, Lucy Randall, who has been extremely patient with me in my delay with my manuscript. So I want to start with actually telling you a bit of a story. And this encounter first happened before the pandemic, but I've been thinking about this quite a bit throughout the last year or so. And I'm really curious what you think about the doctor's suggestion. So this happened on New Year's Eve of 2019, which now feels like a millennium ago. So a friend of mine told me when I was talking to him about the book I'm working on, so he told me about his mother's situation. His mom has early stage dementia and is in a care home, like here in the US, we call it skilled nursing facility. She has her own private unit, but you know, she does have some help in terms of meals and so on and so forth. And so her mom apparently has been telling my friend that, you know, she's a little worried about some of her neighbors and the manager of the skilled nursing facility, or SNF here, that she thought that some people may have been coming into her unit when she is outside and so on and so forth. And so my friend thought that, well, she might have been, you know, just imagining certain things, and given her dementia, maybe she didn't remember that she had moved some of the stuff herself. And so she thought that other people had come in because she thought, why did some stuff get moved? So my friend told his mother's GP about this when they had a visit. And the GP said to my friend, now this, of course, in this, you know, heart of the Silicon Valley, the GP said that, well, actually, one thing that you could do, and it's now very popular to have all these different kinds of monitoring cameras, that you might want to have a camera for your mom. If there's a camera that can actually track her movement and track who comes in and who gets out of her place, then later on, if she complains about somebody coming in, you can just show her the video, and then she can see that actually nobody came in. It was really her who has been moving her stuff. So my friend felt kind of horrified by this suggestion, even though he knew that the doctor was totally well-meaning in suggesting this. But my friend didn't want to tell her that, you know, he felt really awkward about this whole thing. Partly because he thought, oh my gosh, if my mom knows later that I have been surreptitiously like monitoring her, and then other people were also monitoring her without her knowing, and then if later on the camera could show her that she was wrong this whole time, how much more embarrassed she would feel. So he really felt like this might be a violation of her privacy. So I'm curious, and you know, we can come back to this and what you might think about this. But it was actually quite interesting to me how, again, this conversation happened on New Year's Eve of 2019, but what was not acceptable at all now may actually seem quite acceptable or quite common in 2021. I mean, after all, I'm doing a talk virtually, and this is now really the new normal for most of us. I did a keynote for the International Association of Bioethics last year, also actually at the time at my kitchen table, because I couldn't even go to the office. So how may some of these norms actually change the way we think about privacy and what we might or might not want to use technologies for? And it was interesting that I talked to my friend again after, so he did not put in the camera, but after COVID hit, and he said actually, ironically, right now he feels that maybe camera is not such a bad idea, partly because there's nobody really watching his mom, because nobody could come in, and so maybe if there is some other kinds of virtual monitoring is actually better than no care. And this actually has been also the argument being made in Canada as well. Some of you probably have already seen lots of numbers. Even just in a few months, right after the pandemic started, out of the 2,000 plus care homes, in that short period of time, most of the people who died in Canada were from nursing homes. And the number is, astonishing in the sense that people may say, oh, well, in congregate settings, of course, it's a much higher chance that people, if they catch COVID, especially they're elderly with comorbidities, that the chance of them getting serious illness and dying would be much higher. But the astonishing part is when we compare the Canadian number to other OECD countries, between 10 to 66%. So we're definitely at a much higher rate in this country, which raises various kinds of questions in terms of safety for our elderly people, and whether we need to systemically really redesign how we actually care for elderly. So I think that we are now really at a technological, public health, and socio-historical juncture, which raises various kinds of questions in terms of how we actually think about caring for our elderly populations, and how do we think about autonomy as well as privacy as well. Where do people want to live, and how do we actually structure the space that they're living in? What does home actually mean in this very, not very new, but like at least an evolving cultural environment? So my main argument throughout the book that I'm finishing up right now is really to think about how AI health monitoring is much more than a technological process. The whole development and implementation of AI is very much of a socio-relational process that can really affect the meaning of care and familial care relationship. It can also really change the way that we think about the caring profession as well. And I think that the care relationships can particularly be effective for those who might be living at home with familial caregivers or other home care aides. So I'll explain here how the lens of relational autonomy can help us to think about whether AI health monitoring is truly enhancing ethical care relationship and privacies that can really facilitate stakeholder agency and promote health. So why think about home health monitoring? So internationally, life expectancy is continuing to increase, which is a great news, but the aging population is going to double by 2050. So unless our infrastructure really changes, we're going to have a lot of problems in ensuring safety and quality of life for people who are aging. Now, longer expectancy, again, generally is a good thing if people can live in safe and healthy ways. But longer life expectancy also means that people would have more impairments and chronic conditions that may affect their daily activities and functioning. Most older adults want to remain independent, quote unquote independent, and living at home rather than in nursing facilities. In Canada, more than 92% of older adults currently live in quote unquote independent or private households. So they could be living by themselves with family members and so on, but in their own home. About 8% are in collective dwellings, including nursing homes. So the number partly reflects a shortage of nursing homes, but also reflects people's preference and to actually stay and quote unquote age in place. So there's a lot more focus now on how do we actually try to help older adults to age independently at their own home. But unfortunately, in many ways, it's actually financially very challenging for older adults. As I mentioned, that with increasing life expectancy it also means that people would age with more chronic conditions and impairments. But continuous observation of various degenerative conditions, including Alzheimer's and Parkinson's, for example, would require very substantial in-person monitoring and care. And so including in Canada, and many older adults simply cannot afford to have professional care aides. So many would have to rely on family caregivers, most of whom at this point are still women. But as more and more women are in the workforce as well, and they also have sometimes called the sandwich population, they're caring for their own children and also older adults. It makes it much more difficult. So their availability may not always be able to meet the needs of the older adults. There is also a severe shortage of direct care workers. In Ontario, for example, the Ontario Care Coalition actually calls this now the crisis level staffing shortage. And that's the case even before the pandemic. So now, of course, we are even in a much more dire situation. So is AI the answer to promote independent living? Now, of course, and there are, actually even what my friend's doctor, my friend's mother's doctor was suggesting wasn't necessarily AI. She was mostly suggesting like some kind of remote monitoring, CCTV type of monitoring. But, some would point out that they actually, in many ways, of course, can be helpful. If, in COVID time, if you have somebody who is a human operator watching the videos, that could be helpful. But because it still relies on human operators, it's still labor intensive, it may also be prone to distraction and human errors. If the operator is not right in front of the monitor, then you can't do very much. And often it's more of a reactive type of help that you can give, rather than any kind of predictive and more of a preventive responses. So the idea then is if there are ways to use artificial intelligence, particularly in relation to the analytical and the predictive functioning, it may actually help to prevent falls or other kinds of adverse events, that if those kinds of technologies are widely available for people to use in their home or in care homes, that it may actually help to reduce care burdens and improve older adults' ability to live safely and hopefully at home. So there are now different algorithms being developed to collect and analyze longitudinal observation to help track what the older adults' activities may look like, then we can use that to identify and categorize the patterns of the person's activity and use predictive analytics to assess what the person's risk level may be and make various kinds of behavioral and care recommendations. So you see this this product on the right, I won't name the company. It's a company that's actually trying to use a health sensing device with other kinds of smart speakers and other kinds of daily usage on daily activities or daily technologies being built in to make it as user-friendly as possible. It has a lift-out sensor pad that is docked into the top that allows 6 different types of cardiovascular measurements that the person can use the fingertip, a touch screen to activate various kinds of biometrical measurements. And when it is not checking the older adult's vital signs, it can function almost like just a smart speaker. Because it has a screen, it can also show videos, YouTube videos and so on, which I'm sure can actually help to raise blood pressure. So for some of the viewers. So this is a project that I have been working on with my colleagues at UBC in looking at the possibility of using computer vision to assess a person's gauge and fall risk. So this project is specifically to look at Parkinson's. It's still in very early stage of development. Basically, they're trying to use computer vision to recognize a person's steps, how they walk, how steady they are, and to also use computer vision to recognize emotions. And I can come back to this later if you're interested in some of my concerns in relation to this. And so we have been holding focus groups in terms of what Parkinson's patients might think about technologies like this that may be used in care homes and potentially in patients' own homes that would allow longitudinal monitoring. So the idea is that if we have longitudinal monitoring, if an elderly person may not be able to always remember their own activities or how they felt on a certain day, the longitudinal data may actually give a much better and more representative picture of the person's health. Now, and again, I can come back to this technology later on if people are interested. But now, and I think especially given the death rate and infection rate in long-term care in Canada, there are many companies now that want to look at how this may be a way to really harness the potential of artificial intelligence, to see how we can use artificial intelligence in some ways to correct what I would call the botched care. Is basically trying to see, can we use artificial intelligence as ways to actually correct or at least somehow compensate for various kinds of system inadequacy. So some companies are now trying to have these virtual examination room for people to use at home. This can be at care homes or care homes that may not have enough staff members or people who really want to live at home, and especially in COVID, who would want the loved one to be in a nursing home, particularly given what has been happening. So you can use that at home to, to try to track what your loved one and what you yourself may be experiencing. So the idea is that we can allow alert systems, the preventive system in anticipating whether the person may actually have various kind of adverse events, and hopefully to correct that and prevent that accordingly. So these technologies are definitely in many ways in high demand, and from a market perspective, is certainly continuing to grow. It's estimated that by 2026, the global mobile health monitoring market is going to reach more than $236 billion US dollars. So you can imagine it's even much higher for Canadian dollars. So the technology is often now seen as a replacement for dependency on others or to fix system inadequacy. So those are certainly some of the things I've been thinking quite a bit about in relation to dependency, partly because in some of my work on disability really is challenging the notion about whether dependency is normatively a problematic state of being. But the idea with AI health monitoring technologies is to really think about how to actually we can use it to promote autonomy, for people to have better self-management if they choose to, have early discovery or anticipation of any kind of health decline or crisis, hopefully that they would be preventing that. And it may also allow us to have continuity of care between clinic visits, especially when people may or may not be able to remember what may be happening. But with virtual care, that this may allow us to actually enhance people's own engagement and provide and promote high quality care. So many studies do show that patients who are more engaged in their own health information and their own management generally have better sense of also satisfaction in terms of their care choices as well. And of course, COVID has certainly made it much more prominent in terms of thinking about virtual care. And so now many think that this may be actually the prime time for us to really think about how do we actually somehow harness this sort of, I guess, energy and synergy in thinking about promoting more AI care. So I show you that the flip out touchpad technology very much is really about trying to see how we can be as user-friendly and integrated as possible in using various kinds of AI technologies. The assumption is that it can really promote people's autonomy and democratization of information, partly because the information no longer belongs to or may be confined to labs, clinics, or hospitals. So people can now have much more control in terms of when they want to get tested, right? You can just put your fingerprint on there and you can get information whenever you want and wherever you want. So the assumption is that this can really promote quote unquote consumer and patient autonomy. Partly because people can be in the driver's seat to say this is what they want to know about for the day. So questions may be about also whether it can really inform self-management and a much more mutual therapeutic relationship. So you no longer have to wait for the doctor to tell you what your symptoms might be. You can actually just look at the printout and what the recommendations might be from the AI technology. So in many ways, it fits very well with the liberal concept of personhood, because you have this sense of now you have independent, rational, and self-interested deliberators who can really decide what values might be most important to them, what information they want to get, and at what time. So, but I think that there may be questions in relation to thinking about how do we think about AI health monitoring? And if we think about autonomy, whose autonomy are they usually promoting? I don't know how many of you have smartphones with various kinds of devices already built in or other kinds of home monitoring. I'm guessing that Gus may be more tempted to use more monitoring now that they have a little baby to monitor various kinds of safety. But when you look at a lot of the products out there that are really trying to target those who are young, able-bodied, able-minded ones, who generally are actually relatively healthy and may not really need a lot of monitoring, but exactly because they may or may not need it, that somehow that there seems to be this idea that this population has the epistemic and moral privileges of living autonomous lives. So when they are the ones who are being targeted for marketing purposes, we trust in what they know what is good for them, what they would want or don't want. So they are capable of making their own decisions about whether they would like to take on risk and whether they would like to have these applications being used on them, being monitored or not. So I think that a lot of the discussions about or assumptions about autonomy is really mostly focusing on this particular group. People can simply decide that they don't want to buy or activate various kinds of monitoring apps. But I think that when we think about more of the elderly population living at home, there are certainly changing meanings about home and privacy. I don't know how many of you use various kinds of products at home that can turn on your lights for you and do various kinds of things based on your preferences and your behavior. But there are many applications now. They're also encouraging people to post their information online, share with friends as recreational information or something fun to let people know about. So I can come back to this as well in terms of how is that now changing what it means for somebody to be living at home and in the private kind of way. I think that when we go from thinking about mostly the younger, healthy population that may actually not require much monitoring to start with, to the more elderly population, there was a very interesting, to me, a dichotomy there. On the one hand, we want to think about healthy aging and promoting good quality of life. On the other hand, there may also be other kinds of burdens that we're imposing on those who might be getting older and may actually become more dependent or interdependent. So initially, I think that the whole movement about promotion of healthy aging, active aging is really legitimate effort in countering ageism or the negative discourse of decline and disability. Very often older adults are being marked or portrayed as being relatively ill, unproductive, needy, dependent. So the focus for the last few decades on healthy aging have been really trying to think about how can older adults age and at the same time avoid various kinds of diseases and disability, how they can maintain various kinds of physical and mental functioning to the greatest extent possible, and how can they stay active and engaged, because there are certainly lots of really good clinical information to show that more active engagement can also be very good for mental functioning as well. But there is the sense that successful aging is now normative, that older adults are now expected to embrace and sustain various kinds of activities and engagement throughout their later life. And when they don't, there are certainly concerns about the mental health, but there are also some kind of expectation that if you don't, you're not actually really taking individual responsibility of your life. So we see people like in this photo on the right as like the aspirational goal. I don't think I have ever been able to do this, so I think that my chance was done. But I think that it is somewhat of a rhetoric as well in terms of healthy aging. There's a book called something like Our Obsession with Successful Aging, because I think that there are also questions in terms of whether now this dominant biopolitical ethical imperative of thinking about how it is our personal responsibility to take care of our own health, to take care and to be as active as possible as we age, is also then, and in some ways, controlling how we think about people who are not doing all of that or are not able to do all of that. So now I think that there may be a bit of a moralizing framework in terms of your self-regulation, self-improvement, that if you're not doing all these active things and you're not monitoring yourself well enough to prevent any kind of adverse event, that you are somehow not being responsible, or that you may actually be able to be blamed for not foreseeing some of these things happening. But I think that a lot of this rhetoric is also neglecting various social determinants of health and aging, who may have the opportunity to age well, whatever that means. In Canada, for example, social deprivation has been shown to be associated with a 3.7 times chances of having comorbidities. In Canada, about 13% of Canadians report having more than 2 chronic conditions, and almost 4% report having more than 3 chronic diseases. And those who report having more chronic diseases are more likely to be female, older, and more concerning is living in also the lowest income quintile and not having completed high school. So all these other socioeconomic considerations are often not being put into our thinking when we talk about healthy aging, who may or may not have throughout their lifetime actually equal opportunity to be healthy to start with. But then, you know, when we think about impairment and dependency as pathetic or unfulfilled, which is very dominant, I think a dominant kind of discourse in and actually even general bioethics in philosophy literature, then there are certainly questions in terms of whether I think that the rhetoric of healthy aging is really promoting autonomy when we combine that with the way that we think about using AI health monitoring. So as I mentioned earlier, we often think about health monitoring tools as good and valuable tools for healthy aging and independent living. And I'm not necessarily saying that the technologies cannot do that. But what I'm trying to raise here is whether wide adoption or presumption of the values of these technologies, especially the normative values of these technologies, may really mask how different populations may have different or disparate power to resist or accept such monitoring. As I mentioned earlier, when we're talking about younger people, especially if they are tech savvy, they may have a better chance of being able to decide whether they want to use various technologies or not. But for people who are older and people with disabilities, very often the general society is taking it for granted that there are benefits for continuing monitoring for people who are getting older and who have various kinds of impairments. So we assume that they would just accept that protection from continuous monitoring, and that whatever harm or privacy invasion that they may experience, it could be outweighed by these kinds of benefits. And that's even though that many people with disabilities, for example, do have different risk tolerance compared to their caregivers, their physicians, and what the society might think their risk might be. So part of my concern is whether when we think about health monitoring, especially in relation to thinking about older adults, that we're actually creating or having a separate class of individuals. when we think about autonomy, whether some people's autonomy and privacy actually may be less of a concern because of their age or their impairments. Because there are people who actually just being aware of their own susceptibility of being objectification can already lead them to feel being belittled. And this is actually coming out in the focus groups that we are doing in the CIHR project I mentioned. That's one with people with Alzheimer's and dementia. And then some of the people say that I like the idea of having some kind of monitoring, but the whole idea is somebody is always watching me and think that I should never turn it off, feels a little bit condescending, assuming that I cannot at any point just decide whether I feel good enough for that particular day. There may also be questions in relation to thinking about whether people have enough options. So when I think about relational autonomy, I'm looking at a relational approach to look at whether there are enough ways for people to actually decide what type of monitoring would be best for them. Because there may be, we can imagine that different kinds of opportunities may actually lead to different types of benefits or also burdens on different social groups. For example, in Canada, different provinces have different ways of dealing with this, but there are older adults who have been already fully vaccinated in nursing homes. They're still not allowed to go out. It's not quite clear who we are actually really protecting in some of these cases, because those older adults are most likely actually quite protected already from their own possibility of actually getting infected. So we have to really think about how different policies and practices may promote the autonomy for certain populations, but may have other kinds of justice implications and also autonomy implications for other populations as well. I also have concerns in relation to whether there may be funding implications and how that may also lead to different opportunities for choices, quote unquote choices. If it is the case, for example, that people, especially during COVID, now all of a sudden physicians can get paid for virtual visits when for many years it seems like that option was not on the table. But we can also imagine that some insurance companies in the US, for example, or in other places might say that, well, actually, you would only be allowed to have certain visits if you agree to virtual monitoring or other kinds of digital monitoring. And so that to help us ensure that when you want to come to the office, we really have good reason and good data to show that you need to come in. So when you may have various kinds of policies that may evolve given the increasing acceptance of these types of technologies, then we have to also ask questions whether people really truly have the autonomy to decide whether they do or do not want to have these technologies. We also have to be careful too about the bigger ecosystem of elder care. Family members and personal care attendants may not actually have power to reject being also inadvertently monitored. I also think that there are various familial considerations as well, particularly when people are using technologies at home. How may the AI monitoring actually affect the family dynamic and meanings of what caregiving is? So particularly in COVID, I think that this has been actually really interesting, that a lot of people do think that actually, especially when you are in isolation, that the virtual monitoring may provide you some kind of clinical support, assuming that they're actually all accurate and effective and to start with. But that it may also take away the kind of human connection, the relational connections that many elderly people really truly need. And so the AI health monitoring may really change the family dynamic as well. There are other kinds of justice implications I can come back to in relation to how very often we assume that the monitoring technologies can take away some of the burdens for families, but it may actually be the case that in certain cultures, for example, being there in person is how you actually show love and care. So sometimes the use of virtual technologies may then create other kinds of familial dynamics that we may not have actually anticipated. And also depending on how sensitive the technologies might be, technologies that are sending a lot of alerts the project that I've been involved in relation to opioid epidemic, alerts about a possibility that somebody may actually be overdosing in a bathroom in, let's say, a restaurant. Depending on how sensitive it is, it may actually also lead to more fatigue for caregivers or people who may be minding the technology as well. So we have to really think about what does autonomy and consent mean. Particularly in elderly populations, there may also be questions in relation to whether people can have the capacity to actually consent continuously, especially if we're talking about, we're not just consenting to one episode of care or monitoring. When we have continuous monitoring, it's kind of an ironic thing, is that when people's capacity to consent decreases, that it may be the case that clinically speaking, they would benefit more. Possible, but they may or may not be able to say no at a certain point. So there are some who are actually starting to ask questions about advance directives in terms of consenting or declining consent. So I think that there are lots of questions when we think about autonomy, to think about how do we actually think about AI monitoring at home within this much bigger, now I think much wider culture of surveillance. So the public health scene, I think, is really affecting the way that we think about what privacy really means and how much privacy people are now willing to, or perhaps are actually being required to give up. There are also questions in relation to the prescriptive outputs from AI predictive analytics. In our focus groups, and some of our Parkinson's patients who participated talked about how, it might be good if you have a system that can tell me that today might be a day I'm not as steady. But if I actually feel very good, am I able to challenge some of that? And how may that actually change the way that we think about epistemic credibility? If people are reporting their own bodily experience, embodied experience, that may be different than what the AI predictive analytics may be telling them, how do we reconcile that? Some people think that, well, with AI information, or especially continuous longitudinal data, maybe clinicians would actually believe the patients more when the patient can say, well, see, you can see what my tremor have been like for the last however many months or days. But there may be the flip side as well, that if the AI is predicting something that is different than what the person is reporting, how do we actually reconcile that? Who would be able to, or whose report may actually be more trusted or be seen as more trustworthy? And I think that this kind of power and control may actually go beyond the individual level. There may be also professional and system level as well. At UCSF, a lot of my colleagues are talking about issues in relation to professional liability, because in the US it's much more litigious. So if somebody is making a recommendation that is different than what the AI might be suggesting, would they be liable if in the end their suggestion is, quote unquote, wrong or leading to adverse event? Or, the other way, if they follow the AI recommendation despite their own professional judgment and something goes wrong, who would be held liable or responsible for that? So I think that these certainly leads to various kinds of system questions as well. So I think how we think about the acceptance of artificial intelligence as part of this technological imperative and rational choices may really shape the cultural meanings of personal responsibility, whether patients are really being empowered, what does it mean for people to live a healthy way in aging in place, how we think about trust and caregiving as well. The impact on people's decisional context and the subsequent choices regarding AI health tracking and corresponding monitoring or care management may also be shifting given the power of artificial intelligence. And I think in many ways now, even not just AI, but general technology use is already really making it such that if you don't have access to it, if you decide not to do it, you would just not have access to various kinds of services. And right now with COVID vaccine, that's already actually a very important area of thinking about this as well. People who don't have access to a computer, who don't have access to a smartphone, would have a much harder time to recognize or find out where the vaccines may be available, to get appointments, to get follow-up reminders for the second shots, and so on and so forth. So we really have to think about whether people actually have any option to accept or decline various kinds of technologies, and how it may actually place more burden on patients and families, as well as affect the therapeutic relationship. So in thinking more about relational autonomy, I think that we have to think about whether the technology is really promoting older adults' relational autonomy, whether it really allows them to consider their own priorities and goals in how they want to age in place, with or without AI monitoring. If the idea is that there is actually no choice but to accept AI monitoring, then I think that we have to really rethink the whole notion of privacy and autonomy. And as I mentioned earlier, that familial caregiving is deeply symbolic. So there are also the broader questions in terms of how do we integrate caregivers' priorities and concerns. Some caregivers may feel that their privacy is actually more also protected, but others may actually think that they're giving up more privacy. They're giving up more of the time if you have a very sensitive device as well. So how may that actually redefine the norms and the relational identity and role expectation? That in some cases, I mean, maybe that for people who are now using the technologies, that they may actually see themselves and their relationship with the loved one in different kinds of ways. And as I mentioned in relation to smartphone, I think that when people also are not in an infrastructure where they have access to basic information, they have access to the technology and have good digital and health literacy, if they don't have other kinds of access to essential services, the assumption that they could adopt monitoring for their own good may actually marginalize rather than empower them. So in many ways, I think that we really need to have a framework of social justice in thinking about access to various kinds of options in order to think about or to promote relational autonomy. So in a way, I think that relational autonomy in the context of AI is really to think about how we can attend to the socio-systemic factors that may be really influencing the way that people think about their own health, how they want to manage their health and get information and so on. So these systemic factors can then help us to really inform AI development that can truly facilitate people's interests, patients' interests, their well-being, but also in terms of their care relationships that are often for elderly people very important in terms of how they think about their well-being in general. And how may we think about using AI to actually promote health equity rather than in some ways actually exacerbate the inequity of access to various kinds of technologies. Because even in some of the technologies I show you would not be affordable to people who generally lack access to home health care and family members who would be able to take care of them to start with. So we need to critically explore how health systems and governments can invest in digital infrastructure alongside with the health workforce as well. And we want to develop AI health technologies to provide equitable benefits and empower consumers, patients, and families in care relationships rather than simply thinking about how do we replace human caregiving, which seems to be the way that we often are thinking about, particularly because of the changing demographics. So in closing, I think that AI health monitoring is really not a technological process, or at least it's not simply that. It's very much, or I think maybe predominantly, a more interpersonal, a socio-historical, cultural process. It's being shaped by the interpersonal dynamics and the power structures that are already in the society, whether it's familial care power structure or also the professional care structure. It's been shaped by the contemporary medical ways of thinking about how we manage patients' care and also the technological imperatives that tell us that we must accept technologies and that they are supposedly to be more powerful and better than what we have to offer through the human kind of caring. So we need to really think about home health monitoring in the context of surveillance culture and in a very unequal world. And to promote AI ethical development, we need a reflective understanding of the relational and socio-systemic framework within which older adults and their caregivers receive, provide, or utilize such surveillance. Thank you. I can't, oh, I can see the chat now.
Okay, well, thank you, Anita. And at the risk of being interrupted by a crying baby in the background, I can try to take and moderate questions here. I think we should be good.
You can just use a camera for the baby. Predict when Kobe is going to cry, and then we can mute her.
That's a pretty easy prediction. It's like constant. Don't need an AI for that one.
Exactly. We don't need AI for a lot of things, but you know.
Yeah. So yeah, folks, you can use the raise hand function. I'll keep an eye on that, or the chat. That would be good as well. So let's see, Louisa, did I see a hand, or was that like a false start? Maybe it was. Okay, well, Graham, you can start us off.
I don't think I can hear Graham.
I was just telling you that I got permission to take my mask off. The person servicing the dishwasher has left the household, so everything is clear. So thanks a lot, Anita, for the wonderful talk. And you know, actually, those of us with older parents, these are some of the discussions that we're having right now. So I think it's nice to work on this topic of research where you connect to something that's very real in people's everyday lives. So something that I was thinking about, and I think maybe Medhat, who's here as well, might be thinking about himself. He works on robotics, and so a lot of the systems that you described are quite passive, right? Like they're sensing devices. Someone might be remotely monitoring them. But I'm very much interested in this notion of making the systems quite active, as we might be doing, and maybe enabling them with like teleoperation, moving this to remote workers. Could this allow us to kind of outsource some of the care? This would likely pose other ethical questions, right? Of like sort of a new generation of servitude to sort of richer markets. But have you thought much about this? Like, is this helping labor, or is this, yeah, maybe you can respond to sort of the new generation of teleoperated care in an active sense.
Sure, that's a great point. Actually, I want to say a little bit about the passive versus active that had come up in our focus groups as well. Some people thought, oh, the passive monitoring is good if, you know, if I don't see it always, you know, happening, you know, around me, and it's just doing its own work. Others thought that it was creepy for them. Because they may forget. And so like if consent is that you are aware and are still giving permission for the continuous monitoring and collection of your data, that's one thing. But when it's passive, then you have basically forgotten it's happening, especially for our focus group participants who have Parkinson's, and then they think that they are more forgetful in certain days as well. So that may also raise other questions. In terms of helping with in relation to the labor market, and that's actually a really good question, because with the aging population, even personal care attendants are aging. Depending on the immigration pattern as well, which is a whole other global justice questions. We in Canada and the US, we simply don't have the necessary number of younger physically, you know, able caregivers, and for a lot of our Asian population. So I think that's part of the reason why some people think that having so maybe I should clarify, are we talking about outsourcing to technologies or outsourcing to other places?
I was actually talking about outsourcing to other places, people who would teleoperate robots in a parent's house and actually care for them.
Right. So there are one of the groups that I work with in the ethics community. They talked about how actually that some elderly people do feel calmer when you have somebody talking to them through a care bot. But it only works if they don't know it is a bot. If you can somehow convince them that this is a real person or real whatever entity they think it is, that they are actually more accepting of that. And so there may be other questions in relation to how much deception may actually be ethical when we have also the teleoperational devices as well.
Great, thanks. So I think Kieran, you're next.
Thanks, Gus. And thank you, Anita, for a really, really stimulating and interesting talk. There's so much in there. I just want to focus on one issue that I'm interested in exploring further. And so one of the things that has been talked about quite a lot is how AI can sort of have embedded particular kind of value positions, right? And I think this is the case for many technologies, and of course, and you've talked about this as well. And I think in AI is maybe exacerbated compared to other situations. And so we already have trouble, like for example, the whole individualizing health thing. Already as it is even with no technology, it's very difficult to kind of get this point across that health is not really well thought of as an individual responsibility. So to make that point is already a real uphill battle. It gets much more difficult with technology, and then when it gets encoded in AI, it gets even more difficult to make these things explicit. And so I'm interested in exploring this kind of healthy aging notion more and how that might be embedded and what the issues are around that. So I've been stuck more like recently in also in like a critical angle towards healthy aging, largely because of issues you mentioned, such as social determinants and so on. And I'm glad that you actually raised more of the positive issues, and I know I forget those often, that there are benefits to the healthy aging discourse. It does kind of promote a kind of I guess like agency of of pushing back against the notion of inevitable decline. But so what I've been worried about though is in addition to the kind of social determinants argument, is there like a real problem in kind of the denial of death in our culture? In the sense that we are such a youth-focused culture that we don't really deal with the existential fact of death. And so with the healthy aging discourse, what strikes me as really weird about it is the idea that you can successfully, there's also successful aging is also a term that's often used. And so you can successfully age by being active, by maintaining agency, by being able to do all of these sorts of things. And the notion is then like, this is never said, but the idea is then like, one day you'll just die of old age. But old age is not a cause of death. You have to die of something, right? So something has to go wrong. So in some sense, decline is inevitable, because otherwise we'd all be immortal. Right. And I guess so what I worry about is, and I'd be very interested in your comments and thoughts on this. Like, to what degree, is this a problem? And especially when we then even more use as AI to embed these kind of values even deeper into kind of practices and policy.
Thank you so much for that, Kieran. Yeah, I completely agree with everything you were saying, because I am concerned in a society where even in Canada, that there is universal healthcare. I should say that there's universal health coverage, but the access may still be unequal depending on where people live and their trust in the system and so on and so forth. And like you said, that we already put a lot of emphasis on people's own responsibility. This is not to say that people should not be able to, engage and do whatever they think that they want to do. But if the assumption is that it is your responsibility, and if you decline, if you're not aging healthily, whatever that means, it is your failure, right? So that the discourse is really putting it back on individuals rather than saying, how do we promote a healthy environment? I think if we change the discourse to thinking about a healthy environment, accessibility is probably one of those things, right? So people don't have to figure out how to walk up and down the stairs if you have accessible parks, accessible homes, and so on and so forth. So I think that it's okay to talk about individual, quote unquote, responsibility if we have a level playing field, that we actually have a system where we are making sure that people who do want to access various kinds of options do have those options. But when we don't have the options and resources, then, and putting it back on individual is disguising a lot of what I consider to be social justice and injustice issues as if this was just your own fault. And I hear you as well in relation to the denial of mortality and decline. And I think it's partly because in philosophy too, right? When we think about how the able-bodied, particularly able-mindedness is, you know, the highest level of that we want to strive for. And so when we think about autonomy, you know, consent, do we even require consent if somebody does not have the mental capacity? So I think it's a really long-winded way of saying that in a lot of discourses, the intersecting discourses, we are already putting the highest prize on staying at a certain level. So unless we change that and recognize and accept mortality and how dependency is part of human condition. Colby is completely dependent on others right now, right? And so unless we change the way we think about dependency, especially in the older age, it would be really difficult to really think about what autonomy actually means.
That's great, and I'll just second that is the dependency is just an inarguable fact of existence. Okay, so Monica, I think you are next.
Yeah, thank you very much, Gus. Thank you very much for the presentation. It was really very interesting. So I'm in math, so I'm not so, you know, conversant with some of the issues presented, other than just I'm a layman, you know, at large. But I would be very curious to hear your personal take from your vast experience in these areas, which I do not have, on something sort of related to ethics and to the use of technology, and specifically related to the pandemic situation that we're all finding ourselves in. And I'm going to make it fairly pointed. So there is, of course, always a debate between being ethical, and we all want to be, and being effective, and we also all want to be. So I'll give you two specific examples. One, and I'd love to hear your opinion on them. Of course, within the limits of the time. I don't know how the organizers are managing that, so I don't want to be too long. So number one is, you know, what is your take, for instance, in how people reacted to, for instance, introduction or launching rather of these digital platforms, electronic platforms, right, where we were supposed to log in and say that we tested positive, so that other people can be tracked and our contacts can be traced in a much more sort of efficient and much more large scale fashion. And specifically, of course, you're probably aware that, you know, Canada has such a platform. Ontario launched it among the first in July, and I think we're still around less than 2 million adoption for a 13 million population. So it, needless to say, it wasn't a success. And I think, you know, the government said, well, it wasn't a success, you know, because people are hesitant in privacy. But I mean, people also give away their privacy for a lot of social media things that have nothing to do with tracing a pandemic, which was kind of to me, sounded like, you know, we're not going to invest in educating people for that. So I'd love to hear your take on that, because of course, privacy is important, but us being able to trace and test the population is also important. And a second example comes from actually a piece of research that I haven't been involved in, but I know of, is this idea of whether we want to be ethical, but we also want to be very effective in vaccine deployment. So that there again, we want to start with all the ethical groups, the age groups. So within the priority groups, there is a way, if we were very good at adopting technology, of actually identifying people with largest contacts, other than just sitting and saying it's a grocery store and it's the restaurants, right? Which is obvious. So people with more contacts than normal, and target those and then move to the rest of the group. That would be extremely efficacious in the sense of how much we can prevent
right.
once we vaccinate. But of course, that could raise flags as to, is this really ethical? So where do you stand? What is your personal take on these issues, which are hard?
Yeah. Thank you so much for those two questions. And the first one actually is something that I'm working on, and I would probably have a much better answer for you at the end of October. So I'm a fellow for the Emerson Collective this year, and that's exactly what I'm looking at in terms of digital contact tracing and monitoring, surveillance, whatever term we want to use. Because one of the questions, and that's actually what I would not know very much, and mathematicians would probably know much better, is in terms of whether actually contact tracing is best used when the pandemic is in full swing, or when it is actually less people. Because when, in the US in particular places, when the viral spread is so rampant, did it even matter about contact tracing? And it's quite interesting to me because many other places also have the same concern. Unless you have a more authoritarian government, some places require you to have the app on your phone, and that it shows, the green arrow or something. Otherwise, you cannot even enter various kinds of buildings and businesses. You could make people compliant, but there may be questions in terms of what information is being actually tracked. So in South Korea, they would show it on public platforms in terms of not just that a person was here, but they basically use really big data to see where the person was at, which restaurant, for how long, because they also look at your credit card information. So they probably could be actually quite accurate. But the most accurate technologies are probably also the ones that take the most amount of your data. Mm-hmm. And so there may be questions in terms of what is necessary. Do we only use and collect and keep the necessary data for the necessary period of time? And because once people give up their privacy, it's very difficult to take it back later. So I don't know in Ontario whether people really feel that they don't trust the government, even though they trust these other social media. I agree with you that social media use makes me wonder whether it's that people don't realize how much companies actually sell the data, and that's why they would use it, or that because in the government, when they talk so much more about privacy, that inadvertently, when we tell people how much we are protecting your privacy, that gets them psychologically to think more about, oh, I should really think about my privacy now. So there's that disconnect there as well. So one of my questions, and this is more looking at the US in terms of contact tracing, particularly in the context of broader surveillance, whether contact tracing, when used with other types of data, may lead to more inequity. So, because I don't think about the AI contact tracing for COVID is really just about that. Right? So when we were talking about large crowds in the spring, and I talked about this in my keynote for the IAB, the International Association of Bioethics. In the spring and May and June, there were lots of mass gatherings for Black Lives Matter. There are also people then who were taking off the mask. And so contact tracing in certain contexts can actually even tell you who were at political rallies, right? Yeah. So what do we do with all that kind of information, or how might that be used? And especially when police was trying to then find out who might have been involved in any kind of possible violence or other kinds of activities. you could use contact tracing information to see if a person was at some of these gatherings. So I'm not as concerned generally when we're just thinking about if it is a very limited purpose, but again, if we think about the broader culture and broader environment, how we are using different types of data, I think we need to keep that in mind. And so I think that may also lead me to perhaps a very quick, I'm just thinking out loud in relation to the vaccine deployment. We would probably need a lot more data than just who is exposed to more people, right? So probably even when we think about younger populations or people who may be more exposed, if they're younger population, no comorbidities, their chance of getting sick is still much lower. So the only way that we can really probably do a much more fine-grained prioritization is if we have a lot of information about people, not just are you in more crowded areas like grocery store, but what maybe your other kinds of health records and so on and so forth. So I don't know the answer to that, but would that also lead to then also thinking about which groups may be more, hesitant is probably the wrong word, but maybe more deliberate in terms of thinking about whether they should get vaccinated or not, given trust issues. So I like the idea of using math. I like the idea of using data. But going back to Kieran's point, there may also be other kinds of biases. And how do we actually put all of that into consideration as well?
Thank you very much.
Thanks.
Okay, so we've got a couple more questions. So we'll hear from Medhat's question first, and then Edward after that.
Okay, thank you, Anita. This was a quite interesting talk. I want to go back to one of your slides where you put a question about, I think, whose autonomy. And I'm thinking here about three scenarios, and I want to get your take on whether the autonomy here is the same thing. So one scenario is you've got some sensors in a home that is monitoring a person, okay, vital monitoring of a person, some sensors, okay? And the monitoring is done by a person, by a human being, versus the monitoring is done, that's the second scenario, is done by an AI system that would look at, a whole host of data and make a decision, versus a small robot in the house that can actually act in a certain way. So not just it can act. Do you see a difference in the autonomy here between the person being monitored or the person being acted upon? If you are dealing here with a human being on the other end versus some sort of an AI system on the other end, or is there a difference here in the shared autonomy here, the degree where things are? And you touch about trust and stuff like that. Thank you.
Really interesting question. May I clarify the third one first? So it would be a robot at home doing the monitoring and can act.
Yes.
So you
the
can
act here. Yeah. So the act here is very important because the act could also create other problems. So if the robot, for example, can administer a certain injection, or the robot can, for example, help a person move around or bring in a certain medication, or in other words, the robot can change the person's environment, and that change in itself has its own all kinds of logic, all kinds of issues. Things can go wrong, can actually cause problems. So you can see here that it's not just a passive, that the question that Graham was talking about, a passive monitoring, but it's actually the robot can actually, it has its own autonomy. So what I'm saying here is the robot has its own autonomy to act on the environment rather than just observe it.
Yeah, really good question there, because it has come up, and I think I might have put on a slide but didn't actually talk about this, because there are some who say that, when in this technological imperative that we think that technologies are more accurate, you can imagine the robot compared to, let's say, somebody's adult child saying to grandmother, grandma, you have to walk. Grandma said, I don't feel like it. Well, I think you need to walk, but what do you know? But if the robot is supposedly seen as being more accurate, it may be harder for a person to decline if we buy into that notion. So there's that piece. The first two is really interesting because there are some studies that show that people actually feel better when, especially if there are private activities, that they are not being monitored by a person. They feel better than when it's somewhere else by technologies. But it's interesting that I asked this question quite pointedly in one of our focus groups with the Parkinson's participants. And the question was, in terms of the sensors, where would you like them to be or not to be? And many of them talk about they did not want it to be in the bathroom or bedrooms. A couple of people, were thinking, well, no, you still want to know, can you get out of bed? And then somebody mentioned that, but if, let's say your private sexual activities with your spouse might be monitored. Now, if it is AI versus a real person, there's nobody monitoring them, there's nobody watching you. And if you're talking about computer vision, AI, there's nothing that is actually being really represented if you're using computer vision. And so it's all coming to the data rather than, visual images. But some of the participants would still say that is creepy. And so I personally thought, well, if the technology has been tested and it's accurate, and now there's no images actually being stored because this technology is being tested right now, no images will be stored. It automatically, converts to data. And people still said that's creepy. And so, so I think that some people actually do think that their autonomy is lost, whether it is another person watching, maybe less so, but they still don't like it.
Great, thanks. So in the interest of time, we can just move on to Edward's question. And then if there's still time, I'd like to jump in with one after that.
Sure, thank you very much. And thank you for the talk. I mean, really, really fascinating topic. I guess my question, this gets a little bit back to what Monica was talking about, and maybe it's a little bit redundant with that actually, but this idea, actually what you were just talking about, this idea of what sort of data are people comfortable with giving up versus not, and does logic necessarily play a role in that? And do you, in your experience, do people have do they discriminate between whether the data that's being collected and being used is in aggregate form or is in individual form? And the thing that I'm thinking of, in particular, getting back to Monica's example of using these exposure notification apps, another way that you could repurpose them is essentially as an early warning system of where do you expect a lot of transmission to happen, simply by having them do an additional thing that I don't think they do right now, which is essentially phone home and tell you in a geospatial sort of way, where are there a lot of contacts happening, which can give you, if there's a spike in contacts happening in some geographic area, then you may anticipate, okay, there's a higher chance of transmission happening here. On the other hand, Google, of course, as we know, publishes not quite that data, but proxies of mobility, although they have, I think, publicly said that, once COVID goes away, the data is going to go away. So even that is something that they at least perceive people are going to be worried about. So, what is your sense of how people perceive, aggregate data versus individual data? And do you think that COVID has somehow changed that perception?
Yeah, thank you for that. It was a really interesting question. Many people do think that COVID has been changing the situation, because a lot of these apps that people are signing up for, they probably would not have signed up for it before. And it probably also partly depends on what their perception of their own risk in general might be. In terms of whether it's aggregate versus individual forms, frankly, this is the part that I'm not quite sure whether people know whether it is actually collected with identifiers for them. Now, the Korean example that I was talking about is quite identifiable. And some of the reports from Korea is really saying that actually there are certain populations that were concerned, because when they were showing clusters, that it was starting in, you know, a nightclub area in the LGBT community, that more people who are LGBT might actually be targeted in general,
right,
because of how the data is being interpreted. So in some ways, it's probably not just, you know, are we collecting individual versus aggregate data? It's how we report it, how it is, you know, do we have to think about when we use the data, that it has to also be interpreted in the broader context to also make sure there is no targeting of various population groups. One of the questions that I have in relation to the digital contact tracing is, going to your example, I think it's wonderful to be able to know where the outbreaks may happen. And I think that a year more now have passed that we probably don't even need AI to know that in the lower socioeconomic areas, that's going to be more rampant. And the question that I have is, what do we actually use the data for? And so there may be the individual level about, you know, if you have been exposed, you warn individuals. But are we, for example, setting up more mobile clinics in certain low SES areas to make sure that the vaccines can go out quicker and more accessible to people who may need them? So I don't think that it's just about whether we collect the data. It's what do we use the data for? And to balance that risk about inequity, then if we have these other mechanisms to make sure that we are using that also at the population level to make sure that we can equalize the playing field, then I think it's more acceptable. But I think that there's some populations that may worry, like, my data is being collected, but if it is showing in the end, quote unquote, Black neighborhoods are, you know, are more rampant, and then we blame people rather than the conditions that they're in, then I don't want my data to be part of it. I don't want to be feeding into this larger disparity as well.
Thank you very much. Yeah, that certainly makes sense. Very, very thought-provoking.
Thank you.
Well, if it's okay, I'd like to interject with a question too, and it's related to a few of the themes that have come up about, you know, accuracy and efficacy. So, you know, I want to describe just like what I think is a pretty classic kind of bioethics case regarding dementia care, and then, you know, ask for your thoughts on how you think the use of AI, some of the tools you've described, might complicate it. So, you know, I read a piece about dementia nurses a few years back. And, you know, one nurse was describing a way in which one of her patients would constantly ask, you know, when is my husband coming back from the store? He just stepped out to the store, right? And of course, her husband had been dead for 15 years. And what the nurses found is that, like, you know, if they just said, oh, you know, he's out to the store, he'll be right back, within about 5 or so minutes, you know, she seemed to forget about it and was on to the next thing and all was well. Whereas if they tried to explain to her, no, your husband's been dead for 15 years, it tended to cause like quite a lot of distress. So there's this case where, like, you know, you might think you have a duty to tell the truth on the one hand, but then that can conflict with your duty to, like, you know, promote the patient's well-being. And so, like, you know, in the first example you gave about the sort of, you know, accuracy about, no, grandma, like, no one really came in the room and moved your stuff. I mean, do you think there's cases though where accuracy isn't the thing we ought to be aiming at, right? So that if there's situations where it could be justified to use these fictions, if you can call them that, in a way that could have therapeutic value. And, like, do you think, like, could an AI ever tell the difference between, right, those cases when, you know, you want to tell them, no, your husband, you know, just went to the store and he's coming back, or no, you know, he's been dead for 15 years. So, like I said, I think it's kind of like a sort of classic case, but I'm wondering, you know, how you think the use of AI might complicate it.
That's really interesting. I don't know how sophisticated the AI could get in being able to tell the difference between those two types of scenario. We have had certainly some of those questions coming up in some of our care homes as well. Yeah, how do you tell the truth when the person will not remember, and you basically have to re-traumatize the person over and over again? Now, of course, some people may say, well, if we're talking about a person who actually does not have the capacity to understand, then does autonomy, what role does autonomy play, or how do we actually think about autonomy in those situations, just like my friend's mother situation? I don't actually know what my answer would be about the husband has been dead for so many years, but in relation to my friend's mother, it was quite interesting because my friend to say, I don't know for sure whether anyone had come in. But I know that she would be traumatized if she is being led to believe that she's just paranoid or something like that. So I think one of the questions that we might be able to think about is, are there other ways to assure the mother? Or to, like, if it is the case that she would feel more comforted about, whether somebody came to her room, whether there are other kinds of ways, of non-technical even, not technological, can my friend say that, well, let me talk to the building manager or the other people to make sure this doesn't happen, or and so on and so forth. And see what her concerns might be and what her responses might be. So I'm not sure that going to AI, in the doctor's case, she's definitely well-meaning, but my question is really more, why do we often start by thinking that the technology is going to solve the problem, when a lot of these are really the human level problem? The problem for the woman that you're mentioning is really that some of the existential issues that, that we are not capable of really exploring grief and pain and suffering with people. And so, there is the concern about re-traumatizing, but there's also the concern that I don't know how to deal with somebody who is traumatized. So this is a very indirect way of answering that question, that a lot of these issues, to me, are not, technologies are not going to solve it. It's not going to solve the problem with dementia, the woman who is still missing her husband, who hasn't come back from the grocery store. And technologies may be able to help us to disguise the problem. So I think that there is still that human level that we actually have to figure that part out first. So it's a non-answer. I apologize for that.
No, it's probably the right one nonetheless. So I do see that we are at time, 1:30. So I wanted to thank everyone for coming out, and thank you again, Anita, for a wonderful and stimulating talk. And I am sorry to report that I was given very good advice, which is never to wake a sleeping baby. And so we'll have to wait some other time for you all to meet him online.
Can I, before I end, I want to give an example. You can actually Google it yourself, but I might be able to send you the tweet that I found that. Because Kira mentioned earlier about biases. Somebody put on a translation on a Google translator I think this was in Hungarian. Hungarian is a non-gendered language, and they put different things about being beautiful, being a doctor, being smart, being whatnot, all using non-gendered language. And when Google translated into English, almost all of them were gendered, the he and she. And so the biases are often being built into that. And so when we think about accuracy, we have to think about that as well. And so I'm going to end with that.
Good. Well, yeah. So thanks again for the talk, and thanks everyone for coming. And see you for the next installation.
Okay.
Thank you very much.
Bye, everybody.
Thank you.
Bye, everyone.